stretch to think that the DCB is going to take care of the proximal anterior or proximal circuit in any important way, really. Particularly if, in the case that I showed, for example, the main problem was calcium and expansion. If it's under expanded, the DCB is not going to do much about that. So you still have to utilize DCB after you achieve a stent expansion. I don't know I would use DCB in any of the cases I showed, even if I had it. I think DCB is better suited for the more distant and longer lesions and the smaller vessels.
Yeah, George, I completely agree that for DCB, for left vein will be I don't think so, it will be a good idea. My question would be, regarding that a lot of young cardiologists who are doing left vein bifurcation. We wanted to know, just a quick, a lot of people are actually encouraged to do a left vein validity when the circumference is not that big. And they may not address the circumference at all if there is not major pinching. How do you see that approach when you are will make it more simple and you may not do OCT? I mean, of course, in such cases, I personally feel that imaging should be done always. But what do you feel about single stent across LAD in a small circumflex would be a good idea? I mean, if they treat left vein like that also, or should we really be doing imaging in those cases before we finalize the result?
Yeah, no, I think, as I said, that you have to, in every case, you have to see what's a particular scenario that may overwhelmingly help or facilitate the procedure. And I show you a case that I don't normally stand across the LAD in the left vein, I stand across the circumference. However, I did show you a case that had a terrific result by standing across the LAD because of the angulation and the non-absence and the absence of disease and the LAD essentially. But in the case of a small circumflex, I feel the same way. If a circumflex is small, unless it fits an occluded RCA, then you don't really need to bother that much. Because I would treat it the same way as a diagonal, let's say. So you would want to close it, but you don't want to go and utilize a lot of energy and expense and riskier procedure for the small circumflex. I would sort of bypass it. I would use as Colombo used to say, K-I-O technique, keep it open technique, and not achieve corollary.
Just a last comment from your side. Imaging always in left vein or you can avoid in few cases?
I think in some cases, well, I mean, obviously, you know, the majority I would say yes, but I think sometimes it's risky, quite frankly, to do a pre-imaging if the lesion is 95% angulated, etc. You may run into problems, so don't do it. But after some predilation and before the stenting, I think it would be very good to do, and particularly in the initial cases, you have to do a final imaging in order to make sure that the distal dissections don't exist and you have a good expansion and apposition throughout, particularly the proximal part. So even if you had some doubts about pre-imaging, I think it's a good idea, particularly in the initial initiation of this practice, or if you do perhaps the initial double stent techniques in the left vein to check the final final OCT. Thank you.
Thank you, Dr. Jainas, and thank you so much for the wonderful presentation. And we'll move now to Dr. Sanjeev Roy, who's going to be leading a panel discussion on bifurcation PCI and his amazing difference in designing strategies.
Thank you. I'm going to moderate this session and a panel discussion, and I would like to invite Dr. George and Dr. Himanshu to join us in there as a panelist. So all of you know that bifurcation PCI is a complex procedure, left main PCI being more complex than the non-left main, and they usually have worse outcome. If you look at the 10 years data in this impact study, where the mortality rate was 30% in bifurcation PCI compared to 30% in the non-bifurcation lesion, and even as late as the ERB master trial, where the incidence of MI, cardiac lesion evacuation, and stent thrombosis were higher in the bifurcation lesion. And true bifurcation lesion have more worse prognosis than the non-true, and 50% of your bifurcation lesion PCI are actually true bifurcation PCI. So let me ask from starting from Dr. Vivek, do you feel the imaging should be mandatory for bifurcation PCR, and if so, which modality would like to choose and why? Dr. Vivek.
This was a question which I asked Dr. Ganga asked that.
Yeah, that was on left. I'm talking about in general.
In general, I think imaging should not be always, one should not get obsessed, this is my feeling, that in all cases, for example, if you have LED D1 bifurcation, if you are not comfortable, if the patient is not able, in our scenario, especially in our country when the cost is also important, I mean, I would personally feel that imaging should be utilized only if you have a large diagonal, I'm talking about LED diagonal or you have another diagonal. In left main, I personally feel that imaging should be should be used in most of the 95 to 100% cases. Among the IVAS or OCT is a comfort level. I think the person who is using it, and the experience is important. I think OCT has an edge over IVAS, but people who are using already IVAS for a long time should not be discouraged not to use IVAS in those cases. So left main bifurcation, I think always imaging, while in other cases you may still avoid depending upon case to case.
I think your question is a very beautiful question and very pertinent to the answer changes in different parts of the world. In a country like ours where imaging is still only present in about 20% of the centers, and in a country like ours where the patient has to pay for the imaging, the question changes. So, but in an ideal situation, if imaging is available in that cath lab, and if the patient can afford it, so imaging is now a class 1 indication. So if it's available and if it's affordable for the patient and it's a class 1 indication and we are doing a bifurcation situation where we are going to have 2 layers of metal possibly, or possibly with the help of imaging, we might avoid 1 layer of metal. Also, we'll be able to decide upfront what atherectomy to use. If imaging is available and affordable, it should be used in bifurcation lesions. Secondly, I would say that when we talk about IVAS and OCT, both would be pertinent in different scenarios. For example, if I'm doing a left main bifurcation, I would prefer to have IVAS on the shaft. And the other thing is that, but if I'm doing a typically heavily calcified lesion, I many a times like to use OCT to define the situation. The use of imaging also depends on what is the LV function of the patient, what is the creatinine level of the patient. So all of those things, so the decision about whether to use IVAS or whether to use OCT is very individualized as to what is the profile of the patient, I feel. But if it's available, it's affordable, I'd love to use imaging because it really helps us to define the results, pre and post optimization, and also depending on what atherectomy we want to use at that point.
I totally agree with the point raised by Dr. Rao. So the imaging is basically if I'm dealing with a left main bifurcation or anything I'm doing at the left main, whether it's a provisional stenting or it's a bifurcation stenting, I always do an imaging. Then if it's a other bifurcation, it depends on whether the patient is affordable or not as a different scenario, especially in Indian scenario, and what kind of imaging we need to utilize. So if it's the hostel left main, suppose if I'm putting a stent which is coming all the way to the hostel left main or in the hostel RCT, I usually prefer to go with the IVAS because it's still OCT is difficult to negotiate fully visualize the ostia of the left main or the RCA with the OCT. So if I'm putting a stent into the mid shaft of the left main, then I can go with any of the options. IVAS or OCT both are equally good for me.
Sir, for left main definitely yes, and for others if you are directly going for regarding modality, what modality you have it depends, and definitely operator depends. Like Adhijit said, tissue can afford it and it is available. It really helps in assessing the lining morphology and the bar distribution, which actually can have the say on the items of the bifurcation.
Dr. George.
Yeah.
Well, as we said, I agree with the imaging being class 1 indication, but at the same time, I also agree with the fact that we have a lot of logistics that come online doing the regular practice. So, in another situation, you have to make sure that you utilize imaging as particularly to optimize the nerve from imaging to also apply in your other cases that you don't use imaging and try to understand what would you have done without the imaging? Would you have selected a higher balloon and then you go back and look at the imaging and say, oh, in this case, I had to upsize the balloon. Well, maybe you upsize your balloon in other cases as well, that you don't use imaging based on similar angiographic characteristics. It's not optimal, but it is done very commonly. You have to essentially train yourself by understanding better what imaging gives to certain cases and applying those lessons in some of the other cases as well. And I'm not talking about indiscriminately, but with some good judgment. I think that's an exercise I think everybody has done. Actually, very famously, in the beginning of iris, everybody said, oh, we use iris until we train ourselves, and then we know what to do, we don't use iris anymore. That was a very common discussion. And I think we can still apply some of that in order to overcome the limitations of the everyday logistical practice.
Okay. In the interest of time, because the live case is in the maze, and even in the secondary, if you look at the secondary outcomes in the cause or the all-cause mortality, they had a significant impact. Despite that, would you feel that imaging does not make an impact on bifurcation PCI? Dr. Vivek and Sarita.
Sorry, I missed the question.
Of the October trial.
I missed the question. Sarita, can you answer the question?
Yeah, sure. And most importantly, abnormal wiring and stent deformity which was seen in the October trial. What are your comments on that?
I missed the question, so I will answer.
I think imaging always makes a difference in bifurcation PCI. And the more and more you use imaging, I think you extrapolate what you learn in imaging also to your cases which you do without imaging. It always makes a difference because what you see angiographically is not what you see when you image. So I totally feel that with the use of imaging, my bifurcation PCI gets much better. My MACE reduces, my long-term results are very much better. The amount that the patient comes back, the TLR, all that, it gets so much better. So I feel that if I'm doing a bifurcation PCI, I want to have imaging, if the patient can afford it.
I think just to summarize the whole bifurcation, especially for young people, Dr. Sanjeev Roy will always agree, and Dr. Dangas will also, that the purpose is to have when you have a bifurcation, we are talking about significant side branch. Significant side branch means the branch which you would not like to lose. And in such cases, you have to have the best optimized result. And best optimized results can happen either just by doing a non-imaging, imaging, that all depends upon left main, of course, imaging, but another bifurcation should not be always concurrently done. But losing the side branch is a big problem, and therefore you have to have two wires, of course. A single KISS will keep it simple technique, which has also been practiced by most of the interventional cardiologists. That provisional single stent is not a bad idea when you have not that big a side branch. But of course, your provisional means you have to do something in those cases where you have significant pinching or slow flow or loss of branch. But in those cases where you may not utilize the imaging technique, it should not be a mandatory idea to use it. But of course, the best result will come only with final kissing. If you have significant side branch, final kissing technique should always be used. If you don't use a final kissing, of course you will not get the best result. This is my personal opinion.
Dr. George, your comments?
First of all, give me the chance to say that our Society of Cardiovascular Angiography and Interventions, has a very active bifurcation club. that discusses all these things and comes up with position statements, etc. That is in association and affiliation actually with all the different verification clubs around the world. So that's a very hot topic all over. So that's why we made us inaugurate this Skype application club. On the other hand, I have to say that the trial you mentioned, October, as well as many other trials, you really designate that imaging makes a difference. Now, what type? You can decide based on your own practice, logistics, and understanding. But you have to optimize as much as possible and desirably to every patient. How you reduce that into your practice and how you learn imaging slowly and how to utilize imaging more efficiently so it's not a major delay in your hospital, it's up to you.
I think in the interest of time, because the team with the live case is ready, I'll just wrap up this session by just concluding with one remark. Imaging does make an impact. If you have, you should do it in live applications. Thank you.
Thanks so much, panel, and thank you to the speakers. As Dr. Rai already announced, we are ready with the live case. I will request all the panelists one by one to please come forward. And for this, I would request Dr. Atul Mathur, Dr. M. Sharma, Dr. Kapil Bhargava, Dr. R. Mantri, Dr. Sanjeev Roy, Dr. G. L. Sharma, Dr. Jitendra Makar, Dr. Sarita Chaudhary, and also this case will be monitored by Dr. George and Dr. Roxana. So I request chairpersons and monitors to please take it forward from here. Thank you.
All right, we're all set here in the auditorium, and hello, Dr. Sharma and team from Internal Heart Cardiac Catheterization Laboratory. We can see you very clearly, and good morning from the conference center.
Yeah, and good morning, and you can hear us also because we can hear you very well now.
Yeah, very, very well. You can increase a little bit volume from Dr. Sharma's microphones.
All right.
But we're very clear. Go ahead.
Okay. So the key is that myself, Dr. Sanjeev Sharma, of course, and rest of CAT team from ESCC, welcome, and ready to show this live case. And we try to show something different. I know a lot of discussion on the calcific, bifurcation, and that phase. And what about if I say everything is in this case? And not only the what type of effect we do and so. So with that note, we show our small video. I don't know if they have played it. If not, we are ready to show our slides. Which one? Okay.
Okay, we'll show a video to show.
No, they showed the video.
No.
The video was shown already.
Or the video was shown earlier. Go ahead.
Okay.
We can move on to the next presentation. That is complex PCR and imaging guidance. Classified different applications. Next one, please. This is a 75-year-old female who has been hypertensive hypothyroidism for the last 4 to 5 years, and she underlying CKD. Therapy is of 1.5, and EGFR is 27 millimeters. Chest discomfort and dyspnea. NMAX last 2 to 3, and recent in onset for last 2 weeks. ECG shows the left butterfly block, and echo showed EF of 50% except the paradoxical. So as we result result, no significant minor deviation. Next one, please. You can clearly see the diagnostic angiography. Left one is tethering down the distal segment, and that is encroaching upon the LED and circumflex ostium. And circumflex is continuing with a large OM, and that is 90-95% non-segment disease, right from top to mid segment. And go to the next one, please. The yellow caudal view, we can clearly appreciate the distal segment tight stenosis and reaching to the ostium of LED and the circumflex. And RCA has a moderate disease, the body 50%. So it's a typical left classification, Medina 111, a fibrocalcific lesion, and we did the imaging for that. Next one, please. So plan is to do a IVUS guided PCI for left classification, which has been discussed in the last session in very much detail. And definitely the imaging remains class 1 indication in such a kind of a case. And we have planned for doing it attractively with a button after the imaging.
and followed by the vehicles waiting for the final left bifurcation study.
And let's pause 1 second here. I know there's a lot of happened with IVUS versus OCT. And still we have better agent which cannot affect or will not affect the renal. So one of the big, the kind of dichotomy, anybody with a high creatinine like this particular patient, the GFR less than 40, will go with IVUS. Even some people say we can do a little injection with a guideliner and then put a OCT through it, and so, but still some contrast will be used. So this case, we decided to use IVUS, and we are going to show you the IVUS picture. The selecting question which will be part of the calcific discussion later on, orbital versus rotational. Many times you can use both of them, but we thought that we have shown quite a bit of rotational effect in all the live cases, even from here, last year and before. So today we'll show the orbital effect. So orbital is actually, so if we can show what orbital is, first we show the theory and then we show the actual setup. So we can continue our slide presentation. Next. Yeah, so these are the two, we know the rotational and orbital, both are slightly different and different types. The rotational is a core and the that's where the ablative surface. Orbital, it's not at the tip. It is little proximal and very eccentric. It's eccentrically mounted. They call it a crown. So one is the 0.9 wire, 0.09 inch, and this other one is 0.129. Yeah, and we can play both of them. Play the orbital also on the right side. So these are the two kind of the mechanism. They have to play the orbital also. So the little bit of individual differences, I think part of them have been discussed already, and they have to just play the orbital also.
Play the bottom right video, please. Play bottom right video, please.
Yeah. So basically, the why the rotational trajectory is at the tip, and once it crosses, it has done its job. You can do 10 times within the yeah. Orbital. The right is the bottom, they have to play. Play. I taught them outside, yeah, good. Can they play or not? Yeah, now they are good. So your question was I wanted to show a little different. So this is one is a bidirectional and orbital. The name is orbital because it is not only going the horizontal, vertical also, and that is speed dependent. Guys continue to play that, okay. So therefore, you have higher speed, so it will give more into the orbit and have a better ablation and or sending the ball basically. And the slower speed is that. Only problem is the higher speed, which is the so higher speed, 80 and 120,000, and it's a single crown, which is 1.25 compared to rotor which is multiple. Here, the speed gives you different humans, but bigger human or 120,000, which might give you human of 1.8. But risk is you can put more dissection and more perforation, but very effective step. And so only thing is the wire, little difference. Wire is 0.012, which is stripper wire, so short lesions will be covered. But the particle, there is a little difference in the particle generated. Generated particle with a rotation effect about 5 micron, 5 to 6 micron, and below RBC 7.7. But the particles generated by orbital are usually 2 to 5 micron, much smaller. And that is why every study of the rotation and orbital effect we have shown lower slope flow compared to historical rotational. I mean, there is only one trial, head-to-head for 0 trial which compare rotation and orbital. It was more of a imaging study. There was not much difference in slope flow. Even our data, we don't have much difference in slope flow, but traditionally, because of a small particulate generation, it was less slope flow, so that less hemodynamic compromise. So somebody who has a low ejection fraction, you prefer or selectively prefer orbital versus rotational. Otherwise, majority of the time, you can use same as tortuosity, more rotational. Osteal lesion, more rotational. And but hypotension, the LV dysfunction, more orbital effect. So with that note, if we can show our orbital, the diamond back, now it has been taken up by the Abbott, and they are someone marketing it, and this is actually the device. If we show the good. So you see that it's a little size of the thing, just like the road ablation, but all the controllers are on the right here in this advancer. So this is the knob, and this is the brake. Compared to the clip and others which are happen, there is no clip compared to rotor, and this is the brake release. So basically, once you stop it, so this is the brake. And the fluid connection is about the same speed of the fluid infusion. They say slightly faster in the orbital compared to the rotational, the way it is. And these are the two buttons of the, which I would say 80,000 and 120,000 RPM. So with that note, we are ready.
We'll show you the IMS for that.
Now let's show the case presentation which we have taken the picture down. With the acute picture now, this is show our first angio.
Go back one year, please.
Yeah, right. Go to the angio now. Before I was don't go to I was there. Yeah. Now this is our acute. You see that
We have 3.5, 7 sides static catheter. We have 3, we have 3. And it shows that there was a little badging. So there is a plant also involving the most proximal part of the left main. And the display is quite tight. And we can see the corresponding visible calcium also, right from the left main to LAD or stairman also the circumflex. And we've taken up the next piece. This is the first IVUS full back. Next. Show the IVUS.
And now we can show the IVUS of the circumflex. You know the cell, there didn't
I made a picture on the main panel.
Yeah, there didn't be angiography much calcium. There is a calcium in the LAD and that's main, but not in the cell. Can you see it there?
Yeah.
Circumflex full back. Vessel looks like 2.75.
Yeah, calcium at most 90 degrees here, what I'm showing. The rest of the vessel not much calcium.
Yeah,
Very
went
good.
to this kind of part. And there is a thin sheet of calcium here and there.
Calcium up here.
It's a part of calcium thing.
Yeah.
And
Not much, no spot with more than 90-degree calcium, so that's very minor, little calcium.
this is going to
You're coming to the osteum.
coming to the circumflex of the crossing.
Every day? Yeah.
Now the vessel becomes massively big here, is over 3.5, and a lot of black. Black volume, I would say.
Yeah. Now it's coming through the left main distal. Here you can see the circumferential calcium close to 350 degrees.
Over here it becomes black behind the calcium because the calcium was so severe. Now we can see the left main body, which is a flow vessel, and some calcium, some black, not mild black.
Now I'll show you the LAD development for that. That will give us the clarity about the calcium in the osteoproximal LAD and also distal left main. So that's from the LAD. 11 to 4 o'clock.
The 3.5 vessel, calcium, a little bit more calcium.
There it is relatively okay.
Maybe up to 180 of calcium.
There is one of the branch, that will branch. That's of calcium. Diameter is almost 4. The proximal part of the
Small calcium there, no calcium.
LED. Okay, it's coming.
You see the black on the left and the
Yeah.
Pacific between
Yeah.
9 and 1.
Okay.
All right, so what's your strategy?
No. This is the calcium. Yeah, see, full circle of calcium. That is a distal left main, osteal LAD, full circle of calcium, 360 degrees. So with that note, so we are ready with the put-up. We thought with that strategy and maybe Roxanne can make a comment because everywhere else we have heard while we are doing it that we are planning it. We are going to a balloon of the circumflex with high pressure, and for the LAD we are doing the orbital with a 80,000 weight besides 120 because the large vessel, and followed by maybe cutting balloon at the angle to have a good because that circular calcium is a short one. And then decide with the mini press technique. That's our approach. That's what we have been teaching everyone. While we have discussion, we are ready to start and so. So push and pull.
Go ahead. All right, so it's orbital down the LAD, left main LAD, and high pressure balloon towards the circumflex space on the IVUS finding. There was not much calcium in the circumflex.
What's the calcium modification strategy as panel likes to discuss whether you would go for the ideal in such a case, something is not that critical and you can easily across the screen. This is one of the possible strategies, one can argue. I guess you can ask for the opinion of the panel.
All right, Roxana, let's run Roxana out now. IVL versus SHB only. Give one more thought about that. You are ready here?
IVL or not IVL, but one mention I'm going to make before is that because you said, Sharma said that you use sometimes the high speed of orbital. In the few cases I've used high speed of orbital, I use it while I'm pulling back. So I feel like I have more control of how this, so it doesn't jump out of the desirable area and cause a dissection perforation. So on the way back, I may use occasionally the high speed, but not in going forward.
So very good point. So it is a bi-directional, going forward and going back. It takes care of both. So the 1 millimeter per second advancement as well as pullback.
So what vessel size will go at high speed? Not the 3 or below, right?
No,
Yeah,
definitely not. Something like that. Something like this maybe on the way back.
Yeah.
Any other comment?
So start with the 1 or first moving to the
Start with 80 all the way 80. Be very happy with 80. If you want to give an extra mile, maybe do all the way back in the end. As you retract it, you do 120.
So, Dr. Sharma, this is a very, very interesting and very important use of imaging and choosing exactly what you're doing. But I guess one of the big questions is, if you were to be told you can't use orbital atherectomy, what would you be choosing? Would it be rota or shockwave or neither?
This is a good case for good case. So now it's a good case for rotational effect now. Very good case. And now question is, would you use a shockwave or no? I mean, when it's a full circular calcium, I always feel that one cut of the atherectomy followed by multiple cuts which will the IVL will do. So that way, just because of that. So if this one, orbital rotational atherectomy is a kind of legal choice at the time to show what the new technique is. So this way, but otherwise this is a beautiful case for rotational atherectomy plus minus IVL. But I think this one case after rota, our kind of rota cut. We'll just do a rota, do a cutting balloon. If human is good, it extends fine. Why do we need to increase the cost of the IVL? Knowing that IVL cost is everything is incremental, both America as well as India. Now, what we're going to do now, as George suggested, we are going to over the 80 further and coming back to 120. So that's what we are doing. Going to a 120 in this case, which is usually not our type.
Yeah. There's no penalty by stopping and leaving this catheter distally. Unlike rotablator, you have to return every time. You can just go and stay distally. And then let the vessel relax and come back. One more comment.
Dr. Sami, this is Atul Mathur. So, broadly in your routine practice, how do you split your calcified lesions between IVL, rota, and orbital atherectomy?
Yeah, I will show actually our the data once my time will come. But just to say, we do a lot of workshops. So rotational atherectomy, we do about 65 atherectomies per month. Of the 65, 55 will be the rotational, 8 will be orbital, and 3 will be layer. And then about 1/3 of the time it will be combined with IVL. So as you see, we have done this now, and then we break this release, and then we are going to take it out. Also, there is a Diana glide assist, which you can also do, taking the device out. Yeah, but so we have this rotational atherectomy show, and now I can say the future of orbital is dependent on the 3 trials, which will be presented this month, and of course, if it has shown no benefit, I think that is okay, but as long as they didn't show any harm, that has no harm or balloon angioplasty, then of course the use of this device will be very, very low. Now, reason is also there is a difference of about even in America, about $800 between two. rotablation versus orbital. Rotablation is about 1900, orbital is 2600. Here also there is about a difference of 1 lakh rupees between two devices. And if it did not show any additional advantage, then question will come. Why would you go to beyond just using the rotational atherectomy device which has been there for so many years?
That's a good question. Always the differential in the cost makes this question very practical. What's incrementally? May not be
But this case, just to say, this is the case, if somebody wants to use just IVL, maybe okay also because the lumen is good, and you can try the IVL like cases which were shown earlier. Some IVL will not crack that calcium, so you may have to do whether you do rotablation after IVL, which is, we have done about like 8 cases so far in our lab, that IVL didn't work and then we had to use the rotational technique. So it did not provide.
Well, remember with IVL also something else, just to highlight the technique differences. As I said, the number one is you can cross and then all the way and then rest your device distally. And you can start your next round from distal to proximal. The other aspect is that you can stay. Like you saw here, it was the main area was in the distal left vein. You can be stationary there a little bit. You don't have to move. Be stationary to have your maximal ablation in that area. And also produces this very characteristic sound when you're ablating a calcific plaque. You can maintain, you can utilize that in order to stay in that area for more effective ablation. These are just little minor tricks. Terrific result. Now we're going side by side with a workhorse wire in order to be able to utilize the Viper wire as a body wire, or at some point retrieve it, and then they go always with another wire into the sub.
The question is, I always want avoid 3 wires. So now the usual in this case, I think we have to put a wire in the sub also because there is a tight region. So as George mentioned, that it's always good to use as a body wire, so it's like a modified single plate, the balloon scoring technique. So we can have, let's use the 2.7520 balloon for the sub. I think we can remove the fiber wire arms now.
Or just take from the use. If the orbit is not making headway, how long can we stay in one area and how long?
Until it makes a sound. There is a sound that makes that you have to stop and give a break. How you utilize that time, up to you. You can keep moving, or you can be stationary, or you can go one way and then come back. I usually don't like to go and come back. I like to go one way, stay there, take a rest, come back, stay there, go back again. So I use a full one way the time.
So it's a 25 seconds. It's a 25 seconds, so you have to try with your mind. It's just like, rota we do a 20-second ablation usually. So same thing is a 25 seconds, but 25 seconds has to involve coming back also. So you have to put kind of timer in the mind that not only 25 seconds you go forward. Compared to rotablation, you do a packing, go forward. So by packing slowly here, you can gradual advancement. No packing needed, gradual advancement, 1 millimeter per second, and so but 25 seconds it will make the noise.
I have a question here. In larger vessels like left vein and oscillatory, rotablation has to be complemented by IVL or at least a cutting balloon or endoscopy.
Yeah.
You think if we use orbital atherectomy, the chances of having these complementary techniques are less? It works better than rotablation in larger vessels?
So that is true. Go on. So that has been said that for the large vessel, if you are trying to do go to 120, if you can, particularly if you can go to 120,000 RPM, it's not a very tortuous vessel, and you go to 120,000 RPM, it will give you 1.8 millimeter lumen maximum. So question comes is that do you need to? So to me, I think that both devices are very effective. Particularly orbital actually is more effective than rotational atherectomy because of deep touch. The original our 40 patient study, which we showed on the OCT, clearly that orbital caused more deep touch, but at the same time caused more perforation. And that has been our experience also. So it definitely caused a little more trouble, but the point remains is that even with the 80,000 with the RPM, I have to deal with the same way, or with the left main, like this case, if I have to do in Mount Sinai, I'll do the same way which I do for rotational therapy. That do the orbital 80,000 RPM, and let's open the ostium a little more. Let's open the ostium. Yeah. So key is to go 80,000 and then use a cutting balloon because of the large vessel. And particularly if there is a moderate calcium. Now go up here.
This is what balloon they're using now in the circumference?
It's a 2.7520 non-compliant.
No compliant. Let's go 20 atmospheres at least.
Yeah.
Go up there. It's a big vessel. So
Yeah, 22, 24. Yeah.
Go up.
Yeah, we didn't see it opening very well here because of the interruption in the connection, but now we can see that it opens up very nicely.
Take. Sounds pretty smoothly.
And we have a 3.5 that is the same region that we are still going with a 3.5. Now question is, where do you use the IBL? I would say that if IBL is applied on the cutting balloon, you probably use every case, in my opinion, where using a cutting balloon you can use IBL. The biggest advantage of IBL is it's going to cut the calcium without causing perforation.
Yeah.
And but there's a big difference in the cost. So, but I know that by next year we'll have at least 3 other IBL devices. One of them actually laser energy, and they are starting the trial. The trial name is actually fracture, and we'll probably start in 1st January of next year. Uses both the ultrasonic and the laser energy device. So the 2 other devices are in the starting the trials, and by year end, my prediction by year end of 2025 we'll have at least because these are all are single arm studies, no randomization needed. Yeah, go on. This is a 3.5.
I have a comment, a question. Go ahead.
George and Dr. Samir Sharma, congratulations for doing an excellent case. While you're doing a case, something came up to my mind because this is an excellent demonstration of what you're doing with orbital or whatever, and discussion is good. In the case, there are a lot of cath labs in India where you don't have these facilities available. In this particular case, where it's not a huge calcium, I would say it's a moderate calcium. Would you tell the interventional cardiologist of younger age that they can go ahead without doing any such debulking procedures, and if they fail, then they use it as a provisional, or should we have a completely in mind that of course debulking first and then do balloon?
Yeah, I think it's just basically what we believe more. So good idea. We have to go a few millimeters inside.
No, more.
So just to coming back to a very good point. So I think this case, because it's a, remember it's not only the circle, it's the thickness, many things will dependent, thickness and the length. So if you take, in this particular case, we take our imaging score, the imaging score, so this probably will, the score will be, because there is a 360-degree calcium, it is less than 5 millimeter, and it's less than 0.5 millimeters in thickness. Remember we say the rule of 5. 5 means 50% arc, 0.5 millimeter thickness, and 5 millimeter in length. So this one, there's one circular calcium, one that was barely 2 millimeter in length. Let's take a picture and we put a stent. The one barely 2 millimeter and very thin calcium. So taking all those together, it will come in the whether OCP or RBS the score of 1. So that particular case, in my opinion, if somebody wants to just do even high pressure open balloon or using the IBL alone will be good enough. So we are ready with the stent now. Yeah.
So Dr. Samir, I think we are fully satisfied that you see the rule of 5, and although I think your Dr. Samir Sharma's answer are very accurate. I think he gives most of the time one of the best clarification to the ideas of this.
And just make it simple.
Thank you. And we see the coming back to live case now. This is a great result with the dilation, and indeed the most important calcified 360 degrees was in the distal left main right before it bifurcates. So in that exact area, you saw right before the balloon had a little bit of a spot there, and you could really pinpoint that in all these devices were really needed, because if after that we wouldn't have given with a regular balloon, no question about that. So we'll go now with a long stent in the circumflex, meaning crash. Crash will be made with this stent. What do you use, 33 or
3 or 38? 3 or 38. That's what the whole question was. 33 versus 38. We thought that that's our complete team is not much penalty in the structure because it's a good landing zone. Put a wire more, advance the wire more of the structure.
Advance wire more, the circumflex wire. Very good, yeah. Yeah, it's a little long, but it's better, no penalty, as you say. We don't want to, as I utilize also sometimes the bifurcation, you have to decide where you want to look. You cannot be looking very closely, millimeter by millimeter, both proximal and distal, otherwise you will end up missing the most important. So at least you choose a length and long enough, you don't have to worry about the distal, and then you focus with the proximal positioning much better.
Now, in this case, one would also point that we wanted to make a point in the 7th branch, there was a lot of dampening. So I think we had to bring in the LED up to the ostium. So that our LED lesions from left main to LED will bring it up to the ostium of the left main. Keep going.
Yeah, that's fine.
So this is the 4 and this is the 424. I think we should be able to take care of that.
Let's see if the delivery. Usually the delivery of those is more problematic than anything else. In my view, these big stents have always a little trouble with the 7th French guy for whatever reason. On face value, looks like they fit, but in reality, not so easy to fit.
It breaks. Sometimes it bends, I put you and it breaks.
Yeah.
Actually, I had a case I did yesterday. Break. Okay, good. Very good. Okay, so you are ready to take a picture?
So this way, we see that we cover distally very easily, and we're ready to go up essentially with the circumflex balloon.
Ready?
Yeah, we can even go in and look at it. Maybe.
No, start has to go a little more.
Yeah.
Advance start with 2 millimeters.
Yeah, in order to make it mini crush, it's a little bit more of a classic crush.
This looks okay.
Good, go on. No, no check. Go on.
Go.
All
10,
right.
12, 14, 16.
Looking
Negative.
See? And then come back, come back. Come back and do.
And then you can go a little higher. So this becomes a I would say modified decay crash that your ostium, you open it now.
Yeah, it was 20 now.
Bit more, 20 now.
Yeah, very good.
Okay, now you have to take both the wire, our bifurcate as I shown. So now you have to take both wires. Some people do leave the wire, no, because there will be one day you will cut the wire. So both now you have to take the wire out and so. So clearly now, and then you need to make sure that your LED, your other stent does not move proximal or distal, just to stay in position wise. And ideally if you have pressed it, then it has not moved. If moving it, it means that you did not come to the side branch up to the ostium. I think that's good.
Okay, go on.
Yeah, go on. Yeah.
Okay.
Very good.
And 2 millimeters back and go 14. So it's a good 4 millimeter vessel, and we'll do a 5/4 part. Yeah, good. Go ahead. So what I will do, if that's okay, because I know there is a lot of we are behind the schedule. If you are okay, if the pictures look good, the rest is simple. We are going to do a pot and then kiss.
And then do imaging, final
Yeah, final imaging. Right, you are okay that we come out and you start getting your lectures? What do you think?
Yeah, I think so, particularly since the next lecture is going to be orbital versus rotational thoracotomy, based on the case-based this kind of learning. I think that's exactly all the questions that we addressed here. So I think maybe we get ready for this lecture by Dr. Rao afterwards.
I think
All right.
it's important to note, Dr. Sharma, if you're going to do a final small kiss there, and then,
Yes.
can you just let us know that exactly what you're hoping to do? You're going to do a pot and then a kiss, or a
Yeah,
kiss
so
and
question is no. they are very different. The two approach, we always do the case and then port, because otherwise then port, report, all those things they talk about, and even with the non-left main, they do process. Here's why.
No, one second, before you go to port and report, you can see that the distal, the circumflex needs a little optimization there. So the air pressure balloon needs to go first distally, optimize the circumflex stent, and then with the kiss balloon, and then finish with the port.
No, what we do is, we are going to cross now, and then we'll have a 4-0 high pressure, and then 5-0, 4.5 actually, 4.5, right? Left main was 4.5, 1, 2, 4.5, yeah. So yes, so we are going to do clearly that first we cross the LED, and we go high pressure into the circumflex. I mean, we cross the cell, and the high pressure there to open it up. Yes. And then ultimately the spot.
Oh, yeah, Dr. Carr has a question. Dr. Simon Carr, expert interventionalist from Los Angeles, California.
Brief. Okay, so Samir, when you were positioning the left LED stent, do you, like, I always get worried about missing the ostium of the left main, and I usually look at an LAO view. So sometimes because you want to go right up to the ostium, right?
Yes.
So don't you like to do just checking ostium left LAO cranium to see that you not miss the ostium?
It's a very good point. So I think what happened is, before saying that at the time of the imaging, we have established that where we are going to see the ostium, and we found that this view, which we are working, we are actually the kind of one view team that we will be able to see even the ostium in this view. So we exactly went there, and that the calcium was a marker for us also.
Yeah.
Now we are going to because of that, if there is a doubt, you go to another view also. Yes, that is correct.
Thank you.
Okay, this is a used balloon.
Yeah, two issues.
That is 2.5 high pressure. Yeah, open first, and then we go distal. Yes. Now go to distal, there you go 32 atmosphere. That's the one which has not been expanded.
Yeah.
And we have 4 balloons ready? Yeah, 15 is good. Anyone, give it.
Can go here.
We have written there, Go here, 20.
Go further in.
Any advantage of doing the port first in this case?
So I think,
If crossing is difficult, then you can do it.
the point is the port, then they said, well, once you've done the kissing, you have to report again. So because of that, and so port reporting, a lot of people love it. We are not that hot. Actually, if you saw our paper in the JAC intervention, the port technique, where is the evidence? Remember, non-left main, there was a trial called Port Pro, and there was no exactly, rather your kissing was still better than the port in terms of the extent, position and so. So key is that one port. But yes, clearly, the big, when would you do the port right away first? It will be if you cannot go to the side line. But yes, people do it all the time. It was
Small chances of wire crossing by the side of studs in the left main. That is not.
No, initially, when you cross with the circumflex, the guys are very much inside, very much collision.
But you're right. So that is one of the people say that and the therefore technique should be that you put a wire into the LED first and then come back and go to the sun. That's all.
Any question from the panel?
So that's actually you asked a very important question about the port and so.
Another question from the audience. Go ahead.
In one third of the cases, sir is saying, Dr. Samir is saying that we use hybrid IVL with orbital. So after every orbital arthrectomy or rotational arthrectomy, do IVUS at every stage practically, or you see with the fluoro only and then decide to go for the hybrid procedure? One.
Very good.
Number two. The second is that is NC balloon after orbital or after rotational arthrectomy, or the cutting balloon is required in every case, or you decide on IVUS or on fluoroscopy markers?
Yeah, so very good point. So I would say the degree of calcium decides whether you use a cutting balloon or you do high pressure. Secondly, that this distinction should be to do it every time with the IVUS, the real good with those ones. I would say the IVUS imagers or intravascular imagers will do that way, but we don't. We just go by the angiogram. We definitely will do the imaging in the end. So not multiple levels unless it's part of it. You know, like we did the Rotaka trial with the Roxana all the protocols were written. There we did IVUS like multiple times, but otherwise you just decide based on the angiogram. And particularly if you are doing the OCT, then it's a multiple OCT, multiple dye runs is the issue. But I think looking at it now, question is, if just a mild calcium you want to go high pressure after the atractomy or orbital, I think that or rotational, that's good enough. You don't need anything further. But yes, if it's a heavy calcium, then it's better to use a cutting balloon plus minus IVL.
Right. I think
Dr. Sharma, I'm also noticing that you're not using any kind of a support, you know. In the U.S., a case like this, usually people look for some support with so much complex work in the left vein and bifurcation. If you did this, you know, if it was, would you do this with Impella or not?
Yeah. So this case is different. So LV is completely normal. So this is the kind of case I would say, if the RCA is open like in this, but it's for both of them. If RCA is open like this case, I think you can just go away with the balloon and so, balloon pump. But that's really not the entire case. But if RCA is closed, even in the normal ejection fraction, then it's the ideal case for the impact.
Yeah, but I'm noticing that this patient is tolerating, I mean, even with this difficult. So I'm often wondering, are we overusing the protected PCI? And we discuss this all the time, you and I, Dr. Sharma. But when you're in the operating table, I never worry. But it's important to better understand what else is, what other people should be doing and how we could save, resources. But this was a beautiful case, beautiful.
Let's take a question from the audience.
No, Samin and Dr. Roxana, I think I completely agree. Where your concern was hemodynamic collapse during any of the complications if we have during this. Dr. Samin Sharma is having huge expertise. But for young people, I think it's better to have intra-aortic balloon pump, even if their LV is normal, so that if at all there is some complication, you can at least have something to support. Not Impella, of course, Impella when you have very bad LV, then of course. But in this case, intra-aortic balloon pump should be used by all the people, unless you are hugely expert like Dr. Samin.
Dr. Sharma is
So I completely agree with Dr. Roxana Mehran to give this is a really good point which she has picked up, and it's very important for the young people anywhere in India especially, or all over the world, I would personally say.
Yeah, LV function is 50%, ejection fraction is good, and although in India we have come up with the Indian algorithm for use of MCS, and that is one of the talks which I'll be doing in the afternoon. We made up a score based on clinical and technical statistics, and then decide.
From the cell. The question is, I think that has been overrated in my opinion.
Yeah.
Overrated. If you go to the middle, you're good enough. You go to the middle of the strut, that's good enough. Don't waste too much time. What you'll do, you'll cause more deformation. That is both your guide. And remember, the October trial showed 16%. Yeah. And
that was
this
just
is
a beautiful transition of the distal vessel into the distal edge of that stent, beautifully implanted. No issue at all in the distal edge. I just want to say, as I'm looking at this iris.
And a little bit of cardiac last, 4 to 9 o'clock usually, but the little vein looks quite good.
Yeah.
We can go with an NC balloon, a small 2.5 into 10 radish.
So far, very
$2.5. We take 2.5.
Yeah, 2.5.
Yeah, 2.5. Now we are coming to the proximal cell.
Most important is to see what's going on in that bifurcation site that is well opposed there. It looks really good.
we are
we are 1 hour late, so I think we can.
There you go. Just I asked for that, the second that, and we are done.
This is a really important teaching point, you're right, but I think this is such, we're going to use imaging, we talk so much about it in bifurcation lesions, we should know what we're looking at, and I think to me, this is the most crucial part.
The main figure of 8 and it looks quite well opened up distal left main, which was very critical to begin with. There was a calcium 360 degree arc in the distal left main, now it's nicely opposed. So we have to go with the overpermanent balloon, looks expanded very well.
And see that we have one strut outside, so we are good. We covered the osteum. All I did that note.
Let's take a final angio. Take a final angio.
Distal bifurcation.
Good. Show the final.
And with the
I feel
calcium.
like you're projecting from Mount Sinai, but it's really
But
right
in
here,
orbital
EHSS.
Same thing.
Amazing, amazing.
With final kissing and then final IVUS. So it's a perfect.
That's terrific result.
All right, thank you.
Very nice.
That's a terrific result.
Lucky patient.
Let's move on, as we said, with the discussion on the orbital versus rotational atherectomy. Which one to use and why? Dr. Sarita Rao. Okay, and I think the panel will